Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place where I spoon-feed you the latest and greatest of emergency medicine. This is the audio version of the past week summaries, which this week were brought to you by our authors Rebecca DeFabio and Clay Smith. Alright, the first article, titled Executive Summary of the Brain Trauma Foundation Guidelines for the Management of Penetrating Traumatic Brain Injury, 2nd edition, out of the Journal of Trauma and Acute Care Surgery. Alright, I'm going to start off by saying that I've never seen a QR code as a figure in a paper before. And I guess I kind of like it. That's kind of cool. That's kind of neat. It'll lead you somewhere. You'll actually get there. It'll be easy to get to in terms of a website. And we do most things online these days instead of reading PDFs and stuff like that. So, I actually kind of like it. And these guidelines came out because, they say that people, or at least they argue, that people needed recommendations even if there was not a lot of evidence to back them up. So they wanted to put out even poorly evidentiarily based recommendations just so that people have a recommendation as to what to do, and so they're a little bit guided even if it's just by consensus. But wow, I did not realize how consensus-based these recommendations would actually be. Most of this paper is just consensus-based recommendations. So, if you don't agree, take it with a grain of salt, really. A couple of them are backed by evidence, but for the most part, it's consensus-based. Now then, in the pre-hospital setting and the emergency setting, you should try to follow the standard guidelines as is. There's nothing really that crazy here. Make sure your patients are well oxygenated, avoid hypotension at all costs, avoid extreme hypertension, that's not good either, avoid hyper or hypothermia, anything too hot or too cold, everything's Goldilocks. Aim for an end-tidal CO2 of 35 to 40, check the pupils, calculate the GCS, but do so after medically optimizing your patient, and obviously they should be off of paralytics if they're intubated, which in a lot of cases they're going to be with a penetrating brain injury. And then get that patient to a trauma center. You should avoid putting a cervical collar on for penetrating brain injuries that do not obviously have anything to do with the neck. And for the most part, just follow the XABCs that we know of from ATLS. These are good guidelines. Stop any massive hemorrhage. That is always important. Treat any seizure activity aggressively and try to get the head up at 30 degrees. That's all very reasonable. They even weighed in on the fact that massive oropharyngeal bleeding requires intubation prior to packing. Sure, why not? And this is just a consensus-based recommendation. Why even weigh in on that one? That's a weird one. However, they do have a level 2 evidence recommendation that you should do digital subtraction imaging in patients with penetrating brain injuries. Obviously you're going to get a CTA on these patients, but a lot of the time you're also going to follow up with a formal angiogram. And that CTA should be repeated in 1 to 3 weeks because the development of traumatic intracranial aneurysms can be very common with penetrating injuries to the head. Prophylactic antibiotics gets a level 3 recommendation for these patients, and that sounds reasonable. VTE prophylaxis should be started within 48 hours unless otherwise contraindicated. Seizure prophylaxis is for 7 days or more, but they do not recommend any specific drug. These authors also outline signs of medical futility, but I feel like that's just not going to be up to us up front in the emergency department. What you should focus on is stabilizing and normalizing all the parameters of your patients, and then letting neurosurgeons decide on futility or not, unless it's just obvious. Obviously, a lot of the futility assessment is really just going to come down to brain death and criteria like that, not things that should really be done in the emergency department. So in a spoonful, that is the summary of the guidelines for penetrating traumatic brain injuries. Still good stuff to know, especially for a lot of our colleagues who live in very, high penetrating trauma kind of areas. Okay, then let's jump to the fourth article, titled D-dimer thresholds for the diagnosis of pulmonary embolism based on a single question. Is it the most likely diagnosis? A prospective multi-center open-label single-arm interventional study out of the Lancet Respiratory Medicine. This is a study that I've actually been waiting for I think it's 4 years now. Because if you recall, as I hope you do, and hopefully you've been a member or a part of the journal feed in some way since 2002, we reviewed a prospective article which looked at this sort of PE most likely question. And it ended up being called the adjust unlikely. And adjust unlikely was compared to years. Now, what exactly adjust unlikely is that if you think that PE is not the most likely diagnosis, then you raise the D-dimer threshold to 1,000. And if PE is the most likely diagnosis, or for all comers in general, then you can use an age-adjusted D-dimer. And you would do this over using some of these more structured pulmonary embolism assessment tools. Because, Gestalt and just you seeing the patient and you thinking, hey, is it likely or not, is a really pretty good indicator of whether or not the patient actually has any of these things. And most clinical scores, pretty much all clinical scores, will not outperform a decent caring physician, which is hopefully everybody. So the last time we saw this, it was a prospective study that compared it to years. And it missed less cases than years, but years came with a little bit less scanning. So let's see how we do this time. Now, this was a prospective multi-center open-label single-arm interventional study across 13 emergency departments in France. And they included 1,200 patients and had more than 200 PEs in this cohort. Adult patients were eligible if they came to the emergency department with a clinical suspicion of pulmonary embolism, according to the doctor, and they had new onset or worsening of dyspnea, chest pain, or unexplained syncope. Like I said, the overall diagnosis rate was about 7% in the emergency department with those PEs. And if the doctors thought that the PE was the most likely diagnosis, then it was 18%. Now, the diagnostic failure rate of this method was 0.00%, with a confidence interval only spanning to 0.3%. And so this is actually a really safe way to work up your patients, it would seem. It was very safe when it was previously studied and is still very safe. And on top of it, chest imaging was decreased by 19%. And so this is looking really good. Although overall a 33% imaging rate is considered high in most populations, 20% is a much better rate, but all the same. If they had followed the conventional Wells diagrams for this, then it would have been 50% of these patients getting scanned. I will mention as well that if these patients were considered low risk and they could be perked out, they had a negative perk, then they did not get any scanning or D-dimer at all. Those patients were just sent home. So they were also using perk with this, which is really reasonable. I like this. This is very practical. This is probably how most people kind of intuitively practice, unless they're really getting out these scores every time, which of course is recommended by the guidelines. But I have the feeling a lot of people are not necessarily doing, and this justifies that. Of course, you are not skipping the D-dimer step. That is still crucially important unless you really think this patient has a very high risk, in which case skip the D-dimer, just get the scan. But if you don't think they're super high risk, but you do think it's the most likely diagnosis, then you can still increase that D-dimer threshold to 1,000. And hey, as far as I'm concerned, this has seen multiple positive prospective validations. This sounds like an implementable strategy to me. That sounds pretty good. So in a spoonful, if rules are too complicated or you just find them a pain to use, then you can use the adjust unlikely method to decide if your patient should get a threshold for their D-dimer of 1,000 or age adjusted, and this is not going to miss any cases of PE, at least as studied in Canada and now in France. I love it. Okay, that's the 5 articles from this week. What did we learn? First, we saw a summary of the new penetrating TBI guidelines. Then this was the second prospective validation of the adjust unlikely method for ruling out PE, which probably makes it usable. I like it. Now, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were the articles that you missed? Well, we talked about updated guidelines for ACS in females, and I opined on the weird expression, high index of suspicion. Then we looked at new hepatic encephalopathy guidelines, and then finally looked at a SERMA that analyzed the data behind ipratropium bromide for children with moderate to severe asthma. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.